Hello, everyone, and welcome to the final part of the series on how to talk to your clients about their health needs. And without further ado, I'm going to hand it over to Elizabeth for introductions.
Hi, my name is Elizabeth Dixon. I'm an instructor at the UCLA School of Nursing, and I'm here with a group of graduating nursing students who will be receiving their master's degree, and soon will be working with clients across our state. So I'm really proud of them. We are very invested in helping case managers learn more about red flags and health conditions that come your way. And so we hope that this program is useful for you. Thanks.
Okay, so without further ado, we'll start the presentations. We'll let folks slowly trickle in. I know we had some technical difficulties starting us off, but we are going to start with Michelle García Gutiérrez, and Michelle's going to present to us on cardiovascular health. Michelle, take it away.
Hi, everyone. I'm just going to go ahead and share my screen and then get started. Here we go. So just for clarity, I'm going to go ahead and open the chat alongside the presentation. So if you all have any questions at all, feel free to either type them in the chat or just go ahead and unmute yourselves. So again, hi everyone, I'm Michelle García Gutiérrez, and today I wanted to guide you through cardiovascular disease. The goal of the presentation is to sort of get a working idea of how the heart and circulatory system function. So that way, when people say, oh, I have cardiovascular disease and it's this type, we kind of have a working idea of what needs support in someone's bodies. So you can think of the heart as a factory and the circulatory system as a supply line. So if you go ahead and look at the skiff at the left, and you're noticing little blue dots and little red dots going throughout the heart, the arteries, and the veins. So the heart, big thing in the center, works with the lungs to supply the blood with oxygen. And so once that blood has oxygen, it's pumped by the heart through the rest of your body, from your brain all the way down to your toes. Arteries are pictured here in red, and they're how that oxygenated blood travels throughout the body. And so periodically, whether it's your kidneys, your fingers, your calves, the tissues that are there will go ahead and pick up the oxygen from the blood, which they need in order to live and to function well. And they need a certain amount of that oxygen. While that exchange is happening, they are also pumping deoxygenated blood out the other side along with waste products. And so the veins, which you see here, sort of a bluish purple, take that blood and those waste products back up to the heart. And so there, the heart and the lungs filter everything out, re-oxygenate the blood, and pump it back through the system. And so it's just a continuous loop. Cardiovascular disease happens when any part of the supply line is interrupted or is less productive. And so in the next slide, we're going to go ahead and go over some risk factors for what can cause that to happen. So first is high blood pressure, which I know is like a fairly vague term that we can keep really concrete. So it's a condition resulting from a change in force to area in the blood vessels. And what that means is if you think of plumbing and you think of a pipe, right, those are the arteries and the veins and the different vessels that take blood through the body. And so if the vessels themselves are getting smaller, but the force is the same, the pressure goes up. If they get smaller because there's plaque building up around the edges, that means that the heart has to work harder to push enough blood through that narrowed vessel to get to the rest of the body. And so when that happens systemically, we call that high blood pressure. And then you'll see those two numbers sometimes that are read at the doctor's office. The top number, the systolic, is how hard one part of the chamber is squeezing. And the diastolic at the bottom is, I didn't plan on talking about this, but I believe the second part of the heart that's squeezing out to the body, right? So that can be an indicator of how hard the heart's having to work to make this happen. For high cholesterol, excess cholesterol can build up in artery walls. It's like pipes, right? And narrow them, meaning that the heart has to work harder to push blood through. With diabetes, regardless of whether it's type 1 or type 2, sugar builds up in the blood. It causes systemic inflammation in these vessels. And when that inflammation occurs, blood flow can slow down as a result. And so over time, that can cause damage. With obesity, plenty of folks who are obese happen to have, regulated blood pressure, regulated cholesterol levels, but obesity itself and that excess body fat is correlated with high blood pressure, high cholesterol, and the development of type 2 diabetes. Alcohol and tobacco use are both really important determinants of cardiovascular health, and I'll tell you why. Alcohol itself, just overconsumption, which for folks assigned male at birth is more than 2 drinks a day, and folks assigned female at birth is more than 1 drink a day. It can raise blood pressure, make the heart work harder, and it can also raise fat levels in the blood, which can lead to that plaque, which causes a cascade of harder work for the heart. Tobacco use itself also raises blood pressure, but it constricts blood vessels. It's nicotine vasoconstricts. And what that means is that the diameter of the blood vessels gets narrower. So that is how blood pressure increases. It also kicks, if you think of oxygen binding to blood and going through your body efficiently, what carbon monoxide in tobacco does is it kicks some of the oxygen off of the blood. And so even if the blood is flowing effectively to all your tissues, they're still not getting all of the oxygen that they need. And over time, that can cause long-term effects. There are also racial and ethnic components to heart health. So non-Hispanic Black adults are most likely of all ethnic and racial groups to experience high blood pressure, high cholesterol, diabetes, and obesity. And in the references, there's just like a quick 2-page report that is cited where you can go ahead and look at different risk factors for cardiovascular health. The next slide, just a quick heads up, will be fairly dense. And what it's for is just to go over red flags and what this can actually look like in your clients. But what we'll do is we'll go ahead and we'll take it 1 picture and 1 column at a time and work through them. So that way, if there are any questions, there are any concerns, we can just address them one at a time. So just giving you fair warning. Pictures are graphic, my apologies. So here are a few red flags that require medical attention. The one that requires immediate medical attention, call an ambulance, pull out all the stops, is a heart attack. Heart attacks are acute medical emergencies and they require immediate emergency attention. And the reason for that is the pain and all of the symptoms that folks feel when they're having a heart attack are actually because oxygenated blood is having such trouble getting to parts of the heart. The heart is a muscle that pumps blood through your body and keeps you alive. That parts of the heart are dying. And so it's really, time is key. If someone, part of the harm reduction measure, call an ambulance first and then talk with people as you're going through this, because even a minute or 2 can lead to irreversible heart function, and this can be fatal. So signs and symptoms can vary by sex assigned at birth, right? And so for male folks, you have what are known as the classic symptoms. So that left-sided chest pain and pressure, pain in your neck, your jaw, your arms, weakness. If you see someone suddenly breaking out in a cold sweat, having trouble breathing. For folks assigned female at birth, they can also have all these symptoms, but symptoms that are less typical include nausea, intense heartburn, vomiting, and fatigue. And I know that those can also look I don't know, gastroenteritis, right? So it's really important to know that heart attacks generally don't come out of nowhere. They're part of a progressive process of heart disease. So if someone has any of these risk factors that we talked about in the previous slide, they're more likely to have a heart attack. So just something to keep aware of. For heart failure, it's a chronic condition happening in the heart itself. So either the heart can't pump blood out effectively, or the amount of blood that's pumped out is reduced, right? And so signs and symptoms, often like swelling in dependent extremities, right? So like ankles, legs, abdomen. It can be trouble breathing, especially when lying flat. So like if folks are talking about being propped up with 2 or 3 pillows at night, that can be a sign that it's developing. Also dizziness, palpitations, fading, etc. And it's all again part of the system. And this is chronic. It's not like you call 911 right away just because this exists, but these next heart failure, peripheral artery disease, and venous insufficiency all require long-term medical attention. I'll go ahead and keep these next two like brief and connected. So peripheral artery disease happens when tissues aren't able to receive enough blood and enough oxygen in that blood. And so over time they're dying, right? Or waste products are building up. Chronic venous insufficiency, which we're going to see all the way in the far right, is blood is getting there fine, but it's having trouble being pumped back up to the heart. And so part of what you'll want to know when you're comparing these two is just to look for ulcers of any kind on legs, especially like shins, ankles. I've included some information about how to tell the two apart, aside from just the picture. And so just some brief signs and symptoms for peripheral arterial disease. It's sharp leg pain when people are walking that resolves at rest, and just shiny, hairless skin with these sort of like pale, like deep ulcers. And for venous insufficiency, if you see how skin looks really bruised, blood is pooling in people's ankles. And so you're going to see that like darkened, hardened skin. And that also, all of these can be treated with medical attention. They can't necessarily be like solved, but they can be managed, and these are all progressive. So they can be slowed in that progression. And so just to conclude with some harm reduction for cardiovascular disease. One is helping your clients access and take medications as prescribed, right? Because all of these medications have specific functions that are going to help to treat their underlying condition, right? Whether it's helping that diameter of blood vessels get wider, whether it's helping the heart work less hard to do the same amount of work, right? Like all of these medications are there for a reason. And when patients are unable to take their medications or don't take them correctly, those protective benefits go away. And so that's why it's so important to take your meds. And often what will happen, as you all well know, is pill bottles will be lost, or there'll be a sweep, and then everyone's belongings are gone, including their medication. One quick harm reduction technique that I picked up from Eileen, or like while I was shadowing Eileen, is it's possible for providers to just prescribe the same medication. Like let's say you're taking 100 milligrams of something, they can prescribe it at 50 milligrams, and it's just like take 2 pills instead of 1, and that way get insurance to cover meds. So just an option. Also, I'll leave this, all of this will be available for you as reference, but promoting smoking reduction and cessation, as you all can read on the slide, the effects of smoking can't ever be like 100% reversed, but the longer that you quit smoking, the more you start gaining cardiovascular and lung function back. So it's a thing that people can do that has an actual benefit, rather than, oh, stop this and it won't get worse, right? Things actually get better when you quit smoking or reduce the amount that you smoke. Keeping leg ulcers clean, dry, and covered to prevent infection. These ulcers can eventually lead to sepsis and amputation. They're very, very serious. So preventing infection is key. Promoting management of underlying conditions, and then also mental health referrals. When people are stressed out, the heart actually works harder. It thinks you're in danger. It's going to pump blood to your extremities. You're going to want to run. You're going to want to fight. you're going to want to hide, and that over time has systemic effects. So the more you keep your language therapeutic and connect people with mental health resources, the better stress management can help cardiovascular health. And these are my references. Thanks so much, y'all. Do you have any questions?
I want to say a couple of things. One, that was so informative. And I love that you included, where'd you go? I love that you included on your last slide the piece about making the referrals to mental health, because that's not like, oftentimes I think in this field too, we keep them separate, like physical health and mental health. And obviously, like, as you just pointed out, they're so interconnected, and that's such a huge piece. So I really appreciate that you know that, and that is like, that makes me happy, especially as someone going into the field as a nurse, that like you're going to go in and know that, have that information already. And then it's like huge for us to realize too that they are so connected. So thank you for that, Michelle.
Absolutely. Glad that was helpful.
Yeah.
Do you all have any further questions about like how the heart works or any specific conditions? Or do you feel like set with this amount of information?
You did a great job.
Thank you. I appreciate that. Thanks for giving me an extra couple of minutes over time. I'm gonna go ahead and cede the floor, y'all.
All right. Thank you so much, Michelle. I'm looking. Okay, so our next presenter is Grace. Grace, I'm not even going to try to pronounce your last name because I will butcher it. I'll let you introduce yourself. And Grace is presenting on respiratory health.
I could pronounce your last name.
Oh, sorry.
Oh, go ahead.
Hi, everyone. My name is Grace. I'm a UCLA nursing student, and I'll be presenting or talking with you today about talking to your client about some respiratory issues. So when we talk about respiratory issues, we're talking about issues with the respiratory tract, which goes all the way from your mouth and nose down the trachea, and then branches off into the lungs, which branch off into the further into the tiny airways and tiny air sacs inside the lungs. So if you see in this picture here on the far right, there's a picture of kind of what the little air sacs called alveoli look like, where oxygen from the air is absorbed into the body. So a respiratory issue can happen, can be a dysfunction anywhere along this pathway. And people experiencing homelessness are at a high risk for respiratory damage due to high prevalence of tobacco use, drug smoking, and adverse environmental exposures. So as you might suspect, lung diseases are a common health concern among the homeless population and can include illnesses such as tuberculosis, pneumonia, and influenza, as well as chronic conditions, including asthma and COPD. And today I'm just going to focus on asthma and COPD. And I'm just going to note too that some studies have found asthma and COPD to be as much as 2 to 3 times more common among people experiencing homelessness than some housed populations. So asthma and COPD, what are they? Asthma is a chronic respiratory disease in which airways become inflamed in response to a triggering substance, such as secondhand smoke or allergens, or behavior such as exercise. And so as you can see on the picture on the left, in response to the trigger, the airways become swollen and narrowed. They may even produce excess mucus, and the smooth muscle of the airway can constrict. You may have heard the term bronchoconstriction, and that's this. So all this together makes the airway become narrow and makes it difficult for air to flow in and out and makes it difficult to breathe. While there's no cure for asthma, it can be managed by avoiding triggers and taking medications. But if not managed properly, over time, the airway actually remodels itself. The muscle becomes thicker, making it more narrow. at baseline and prone to more symptoms. And even though people often think of asthma as something that you get as a child, you can develop it as an adult as well. Now, chronic obstructive pulmonary disease, or COPD, is a chronic, progressive, meaning it gets worse over time, lung disease, which causes reduced airflow in the lungs and thereby difficulty breathing. You may have heard the terms chronic bronchitis and emphysema before, and these are both conditions that fall under the category of COPD. So the picture in the middle shows chronic bronchitis, and this is where the airways are chronically inflamed and produce excess mucus. And in patients, you might see this as a chronic cough, or like you may have heard the term smoker's cough before. This is a manifestation of chronic bronchitis. And on the right is a picture of what is going on in emphysema, which is when there's damage to the small air sacs in the lungs. So you can kind of see in the picture that the air sacs are, the walls between them are damaged. They're bigger than normal. So what happens is air gets trapped in there. It has a harder time getting out. Fresh air has a hard time getting in. And this makes it more difficult for air to flow. Air isn't flowing as easily. And actually, sometimes you might see patients or clients with COPD have somewhat of a barrel chest because they've been having air trapping in their lungs going on for a while. And most people with COPD have both emphysema and chronic bronchitis. While there's no cure, its progression can be slowed. Next, I'm going to talk about some red flags that somebody might have asthma or COPD, or that they may be experiencing an exacerbation. So shortness of breath, which can also be described as difficulty breathing, breathlessness, or air hunger. You might also see a person leaning forward to breathe more easily, like in this picture here on the left. And that can be, we call that tripoding because they're kind of forming a tripod with their body. Wheezing, which is a whistling or squeaky sound while breathing. Chest tightness, which might feel like the chest is stiff, being squeezed, or a feeling of pressure on the lungs. And coughing, which may be accompanied by excess mucus production. And in COPD, this is a chronic or ongoing cough. And now some of these symptoms it's important to keep in mind they're not exclusive to asthma and COPD. So just keep that in mind as well. Now, what can you do if you're with somebody when they're having a COPD flare-up or an asthma attack? And what is this? Well, basically an exacerbation is when symptoms noticeably worsen, requiring a change in the person's normal treatment. So like, say they're taking their daily medication, but all of a sudden they start feeling more short of breath or start coughing more. This can be an exacerbation. And with asthma, this can come on gradually or suddenly and may be pretty severe, even life-threatening. With COPD, a flare-up usually lasts 2 days or more and often has early warning signs. But either way, if you are with a client with asthma or COPD who's having an exacerbation, here's a few things you can do. Stay calm. This will hopefully help the client to stay calm or calm down a little bit, while panic only worsens symptoms. If not already, help the client sit down. You don't want them to lay down because this can make it more difficult to breathe, especially if they have a lot of secretions in their lungs. Also help the client take their prescribed medication for flare-ups. So like a quick relief or rescue inhaler, maybe you can just grab it for them from the cabinet or from their bag, or, just see if you can help them with that. And then in a couple slides, I'll be going over how to use an inhaler. Stay with the client, encouraging slow, steady breathing. So I'll also go over a technique that you can use for that. And then call 911 if at any point the client is having trouble getting words out, their lips are turning blue, or if symptoms are not improving with use of medication, or if at any point you're worried. A lot of times difficulty breathing is a emergency. So if at any point you're worried and the client is worried, call for help. One other thing, if you think this was an allergic asthma attack, the patient and the symptoms aren't improving with inhaler, the patient might have an EpiPen that they can inject into their leg. So that's something to keep in mind as well. So on that note, I'm briefly going to discuss inhaler use. So looking at this picture here, as you can see, first you just take off the cap and shake the inhaler 10 to 15 times. And then if they have a spacer, this is when you attach it. Then the person breathes out to empty the lungs. They put the spacer in between their teeth and close their lips tightly around it. They put their chin up, puff, press one puff and breathe in as deeply as they can. After breathing in as deeply as they can, take the inhaler and spacer out of the mouth and hold the breath for a count to 10. This is an important step. If holding the breath will help the medicine to reach deep into the lungs, and then pucker lips to slowly breathe out through the mouth. And for most quick relief medications, inhaled medications, it's good to wait about a minute before taking the next puff, because this allows the medication to really take action in the lungs. And you might be wondering, what's a spacer? It's kind of like a holding chamber to help more medication get into the lungs. It makes so that the client doesn't have to have as much coordination with when they breathe and puff, and it, not spray all over the sides of their mouth, but they can, it holds the medication in there so they can just breathe it in, and if they don't have a spacer, you can use like a water bottle with a hole in the bottom as a spacer if they're open to that. Next, I'm just going to go over briefly pursed lip breathing, which is one technique that you can do with clients when they're short of breath. It helps slow the rate of breathing and make it more effective. So first, you just want to sit down and relax your neck and lip and shoulder muscles and breathe in slowly through your nose, feeling your belly get larger as you breathe in. So 1, 2, in through the nose, and then pucker or purse your lips as if trying to blow out a candle, and try to exhale for a little longer than you inhale. And this is something that you can teach your client to do on a regular basis. It's just a handy thing to have in your tool belt. If you know your client has asthma or COPD, this can be handy. There are other breathing exercises that you can do as well if you know those, but this is just one of the commonly recommended ones. What are some actions also that you can take to help prevent asthma and COPD exacerbations? One is just obtaining and taking medications as directed by a provider. And this looks different for everybody. Some people might only have a rescue inhaler for exacerbations, but other people might have a daily pill that they take or a long-acting inhaler that they use daily. Something to keep in mind is that albuterol, which is commonly found in quick relief inhalers, is used to enhance the effects of cocaine, so it can have a high street value and may be stolen or abused. And so the client may need a replacement, or maybe collecting some, just something to keep in mind. Also, find out if the client wants to quit smoking or reduce smoking. Cigarette smoke is the most common cause of COPD in the US, and quitting smoking is the most important step a person can take to treat COPD. Cigarette smoke is also a common trigger in asthma, so if you can help the client avoid secondhand smoke if possible, I don't know. Also, try to help your client see a healthcare provider every 6 months, if possible, to monitor symptoms and medication usage, and know your client's asthma triggers. And the most common triggers for asthma are secondhand smoke, dust mites, mold, cockroaches, pests, air pollution, chemical irritants, could even be exercise, cold air, stress, and strong emotions. So there's really a wide variety here. So for instance, perfume shampoo may trigger someone's asthma, and it may be helpful to go with something a little less strongly scented when you're with clients, or maybe don't play with your dog and get dog dander all over you right before leaving for work and visiting an asthmatic client. Just be cognizant of your client's triggers if possible, and see if there's a way to reduce allergens in their living environment. Finally, help clients get their vaccinations, including the yearly flu shot, particularly for people with COPD. Certain illnesses and colds can lead to flare-ups. And obviously, there are many other respiratory issues besides asthma and COPD, pneumonia, TB, lung cancer, to name a few. Just try and open up the conversation about respiratory health with your clients by asking about their breathing. How's your breathing? Or do you ever have trouble with your breathing? Can be questions to start the conversation. If the answer is yes, find out more. When did this start, or is this new? If you see them coughing a lot, ask, is this a new cough? And if so, see if they're open to visiting a provider and if you can help them schedule a visit. Find out if they've ever been diagnosed with a chronic respiratory condition like asthma or COPD, and do they have an inhaler? It may also be helpful to find out if the patient has had COVID. Many people have experienced post-COVID conditions with persistent difficulty breathing. And finally, like I said earlier, there's a lot that can be going on with respiratory conditions. So it's a good idea to help connect clients to a provider if they're open to it and haven't already. Here are my references, and sorry for going a little long here. If anyone has any quick questions, I'd be happy to try and answer.
Hi, Grace.
Hi,
Oh,
Eileen.
there you are. That was a good job. I just wanted to add a few things in. As far as the inhalers, you very rarely see the spacer anymore. Most people don't have it. So for everybody, just like with a regular albuterol inhaler, you're just going to shake and inhale like that. You don't, without the spacer. A lot of people have other inhalers are steroid that they might use twice a day. So I don't know if you're familiar with this one, but you just go like that, and then they inhale right there. So the other thing is, in an emergency situation, which were all good, really good things, tips you said, the first thing I would say is, do you have an inhaler? Right off the bat, first and foremost, do you have an inhaler? And then it's really weird, like years and like a gazillion years ago, a doctor told me, like during an asthma attack, that apple juice sometimes helps clear apple juice. And I don't know how that works, but I've seen it, it's been helpful. And then just one other thing for the homeless population, or even clients that have COPD, or they're always wheezing with their asthma. Another thing that you can, is really good, is for them to elevate their head at night when they're sleeping. Put several pillows up and make sure their head is elevated, and that's always helpful. And that's all I had to say. Thank you, Grace.
Thank you. That was awesome how you could just pull out your inhaler and show us all. Thank you.
I have a question, because now you both have brought up the Grace, like you were saying, don't lie them down. And then Eileen, you said like to keep their head elevated when they're sleeping. Why is that? Do you guys know?
E.
Huh? What'd you say?
Eileen is chewing. um, for my understanding is that when you sit up, it kind of allows gravity to work and like let the lungs fully expand. Also, in terms of gravity, like if the person has secretions in their lungs, it helps it to like sink to the bottom so they don't feel like they're drowning in secretions, you know? And so that at least they can get more air into their upper airways. But yeah, that's like one of the first things in the hospital we do. If somebody says, I'm having trouble breathing, you raise the head of the bed. So
Right. Katie, think of it in terms of just the open airway, that if you're choking, I mean, you wouldn't have somebody lie down. So
Right.
if you're, you know, wheezing, you know, and it's difficult to breathe, it's easier to cough up secretions or to sit up just so the airway's open.
Ah, okay. That makes
That
sense.
is, I'll have to say, a stupid question. No. I'm kidding.
I'm not of the belief that there are no stupid questions, so it's okay.
There are many stupid questions. Is the earth round, flat? That's a stupid question.
Depends on who you ask.
Okay, right. Okay.
Does anyone else have any questions for Grace or Eileen or anybody?
Good job, Grace. That
Yeah.
was good.
Well done, Grace. That was very informative.
I'm so
Okay.
glad. Thank you.
There are stupid questions, though. I believe there are no stupid questions.
You know, you're on record now forever saying this, so. All right, let's move on to our next presenter.
Am I tall? That's a stupid question. Okay.
Mute yourself.
Oh.
So our next presenter is presenting on vision health, and we are hearing that from Peiran Lu. Take it away.
Okay, thanks everyone. I'm just gonna screen share real quick. Okay, so hi everyone. My name is Peiran. Can everyone see my PowerPoint? Okay, great. Today I will be addressing vision loss care for people experiencing homelessness. On the right, I included a holistic view of the various services that are, can you see this screen as well? My presentation and my quote speech as well.
We cannot see your notes. We do see like the top of your screen, but
Okay.
no notes or anything.
Okay, okay. I just wanted to make it clear. Hold on. Sorry, a little bit of a technical difficulty here. Okay, sorry. Okay, so I included a view of the various services that are often used to care for people who have vision loss. That's the wheel on the right. However, I know that in our client population, they don't have access to many of these supportive services. So today I will mainly focus on promoting health, safety, and slowing the progression of vision loss. Okay, so there are 4 different terms that describe vision loss. We'll start off with someone who has functional vision loss, and this means that they have poor eyesight, but they can still perform their normal daily activities. And then the second kind is someone who is experiencing low vision. And this is someone who can no longer perform their normal activities as a result of their vision impairment. And then legal blindness is something that must be diagnosed by a physician or an optometrist, and their vision is diagnosed as less than 20/200. This means that the person who is legally blind must be closer than 20 feet to see what a person who is not vision impaired can see at 200 feet. And then finally, total blindness is someone who has no vision at all and cannot differentiate between light and dark. So there are two main areas of vision loss. One type can be corrected with glasses, and the other kind results from diseases that progress over time. I will talk about some common eye diseases that cause vision loss and cannot be improved with eyeglasses. This first disease is called cataracts. This is caused by proteins that are clumping inside the eye, and this occurs with age. This gradually makes a person's vision to be cloudy and blurry. So I included a picture on the right, which shows what this person will be seeing. It's like very blurry vision, and the colors are kind of fading over time. So if you talk to a client and they say that they have really bad night vision and they are very sensitive to the glare at night from the lights, this may indicate the beginning of cataracts. Some common causes include smoking, UV damage to the eye from the sun, long-time steroid use, trauma, and diabetes. Most of the eye is filled with fluid that is constantly being produced and drained to keep the structure of the eye intact. But in glaucoma, the draining system fails and fluid starts building up over time to increase the pressure inside the eye. This leads to nerve damage and vision loss eventually. Loss of peripheral vision is a key sign of glaucoma. So the image to the left shows that central vision is still visible, but it is dark everywhere else. In some cases, mild pressure in the eye can be relieved with eye drops or oral medication. Some common causes include diabetes, hypertension, long-time steroid use, and genetics. These illnesses occur over a period of time, and the only way to reverse the effects of vision loss is to get surgery. Since many people experiencing homelessness have to wait a long time for surgery or don't have access at all, I will be discussing some safety practices and ways to slow down the progression in the next slides. So the last disease I'll talk about is the age-related macular degeneration. This is probably the most severe one because there are no treatments that can reverse the effects of vision loss. It has a genetic component, but also weight gain, smoking, and again, UV damage from the sunlight to the eyes are factors that can increase the risk of this disease. It's caused by damage to the back part of the eye called the retina, and this leads to a loss of central vision. So in this picture, you can see that there's no vision in the middle. This can make daily tasks like reading or facial recognition a lot harder. So here are some red flags of vision loss that may require more urgent care. Let's say if you're talking to your client, they say, my eyes hurt and everything suddenly got blurry. This may be a case of sudden glaucoma, and this type of glaucoma can be reversed if your client seeks care within 24 hours. If you see your client with bloodshot eyes, like in the photo, and they complain of pain and blurriness, for instance, this could be a severe form of pink eye, also known as conjunctivitis, and that can lead to permanent vision damage if left untreated. If a client says that they suddenly lost their vision, like a curtain has dropped over their eyes, there's no pain, and then over a few minutes, their vision came back. This could be a result of loss of blood flow to the eyes and maybe a warning sign for a future stroke. Red flag number 4 is when your client experiences sudden and total blindness. This could very likely be a case of stroke or trauma. So usually a case of double vision may have less severe causes, but if a headache is involved, this could be caused by increased pressure inside the brain. If your client says they hit their head or fell or something like that, a combination of head injury and these other symptoms could indicate need for urgent care. The 6th red flag is seen in the drawing shown, where you can see it in your client. When your client suddenly shows up with a much larger pupil size in one eye, while the other eye is normal, this may be due to nerve damage to that eye, and seeking urgent care can help treat that. There are a lot of causes for larger pupils, but if it only happens in one eye, this is a cause for concern. Here are some other things you can do to improve safety for clients that have vision loss. Sometimes people with corrective glasses may lose them. You can help your client obtain a retainer for their glasses, and this may help lower the risk of loss. There is also a way to make a retainer with 2 strings and a technique called a fisherman's knot. I have attached a video link to that. You can also check your client's shoes and make sure they are fitting well to prevent tripping and falling. Another safety precaution is to help your client get what's called a white cane. It's a long cane used for probing and detecting objects in the client's way by sweeping it back and forth in front of them. And I attached the link to an application for a free cane. For clients that are staying at a shelter or have temporary or permanent housing, safety precautions include making sure the area is well lit, offering your client help to organize things, as clutter is a risk factor for falls. You can help create a list of important phone numbers or addresses in large bold print, or you can also write it on bold lined paper. When possible, mark stairs with brightly colored tape. You should always wait for the client to take your arm first, and then you can help walk the client around the room to get them familiarized with it. And then another thing is to not leave doors ajar, to either fully open or close them to reduce fall risks. So there are several different ways to slow down vision loss. The eye diseases mentioned before are linked to smoking, their head or weight gain and sunlight damage to the eyes. So you can gauge your client's interest in smoking reduction, maybe their willingness to not gain more weight, and if possible, have them start wearing a hat to protect their eyes from direct sunlight. If clients are being prescribed medications like eye drops for their glaucoma, you can remind them to use them as prescribed. Additionally, to help reduce increased pressure in the eyes, positioning does matter. You can advise your client to avoid positions where the head is below their heart, like if they're trying to do a handstand during exercise or something, or if they're leaning over a lot, or if they like to sleep on their belly, they can try to sleep on their side or their back instead, as this will also help reduce pressure in the eyes. Recent research has reported that these eye diseases can be slowed down with the consumption of foods high in antioxidants. So this would include eating larger portions of fruit and vegetables when possible. Caffeine is an antioxidant, and research shows that drinking just 1 cup of coffee a day over time can lower the incidence of glaucoma. Vitamin A, E, and C slows down cataracts and glaucoma progression, and also is effective in reducing the risk of macular degeneration. Some examples of foods that are good for their eyesight are listed in the table on the right. Some foods like eggs, leafy greens, and sweet potatoes have multiple antioxidants. So this concludes my presentation. Thank you for listening. Do you have any questions?
That was great. I appreciate you putting in the link for the free cane. That is the kind of stuff, like when we are digging for resources, that is really helpful. So I definitely appreciated you throwing that in there. Okay, if nobody has any questions for Peiran, thank you so much on your presentation, and we'll move over to our last presentation of the day, which is the most exciting. This presentation is going to be presented by Jenny, and it is on diarrhea. Take it away, Jenny.
Hi guys, we're gonna start. Hold on, give me a second. Let's see. Can you guys see this?
Yes.
Okay, so last but not least, we're gonna end with a bang. No pun intended on that. So hi, my name is Jenny Mai, and then we're gonna be talking about diarrhea and gut health. Fun stuff. So just gonna a brief overview of the condition of diarrhea. So there's a lot of common causes for diarrhea, both acute or sudden and chronic diarrhea. So why should we care about diarrhea? Because each diarrhea episode can lead to malnutrition. And a lot of our clients being in like homeless, it's really hard for them to find food and access to healthier food. So this can lead to some serious issue. So, and repeated diarrhea can lead to long-term gut damage that prevent nutrient absorption and immune system function. As you can see in the chart on our left, some sudden diarrhea is like food poisoning, traveler diarrhea, or stomach flu. And the chronic is celiac disease, irritable bowel syndrome, medication and their side effects, lactose intolerance. But for the sake of this presentation, we're going to focus on the acute or the sudden diarrhea, which is stomach flu and food poisoning. So for food, let's start with stomach flu first. Stomach flu is the swelling and irritation of the stomach lining and the intestine lining that caused by a virus. The most two very common virus is the norovirus and the rotavirus. And this can cause by when someone is in contact with someone else that have the virus because it is highly contagious. Touching contaminated surfaces that have the virus on it can also cause it. And unwashed hand from after using the bathroom or handling fecal matters can also cause the stomach flu. As for food poisoning, is usually caused by either virus, bacteria, or parasite, but the two most common is E. coli and Salmonella that's found in contaminated food. And the onset for the symptom is very fast. So usually when you eat like uncooked meat, handling food without washing your hands, eating something that was contaminated or was grown or touched the salmonella, the E. coli can also happen. And the symptom of this is usually very fast. Within 2 to 3 days, you will see an onset of diarrhea and other side effects that we're going to talk about. The main difference between the onset of stomach flu and food poisoning is that food poisoning usually happen quicker and then the stomach flu. And the duration is another thing that we can look at to kind of see the difference. Usually food poisoning will be resolved within like 24 hours. But for stomach flu, it usually can last up to like a week. And this is some red flags that we can look at for when we trying to see diarrhea and why it's happening. The symptoms between stomach flu and food poisoning is very similar. That is diarrhea, vomiting, nausea, body aches, stomach pain, cramps, and a lot of time our client can feel weak, very weak from all the vomiting and diarrhea, and fever, light fever, because our body is trying to fight off an infection. And lastly, loss of appetite and weight loss. But what are some major red flags that we should be worrying about? First is dehydration. A lot of the time, when we think about diarrhea, we don't really think about hydrating, but it's a very big thing because if you're unable to keep down any fluid from vomiting or diarrhea, it's hard to have a balance in the electrolyte in our body. And if you look at the little chart I have on the left, you can see some symptom is like, we can look for our client is like, if someone's saying, I'm very thirsty, or if they have dry mouth or cracked lip, they're very no urination. We can ask like, hey, when's the last time you go to the bathroom? And if you go, like, what do your pee look like? Is it like very dark color? If so, that's a sign that we should really get help for them. And another thing is dry skin. What we do in nursing school that we got taught is that when someone have dehydration, their skin doesn't have the elastic. So what you can do, we call it skin tutor. We can literally just pinch the skin, and if you see that it relapse immediately, then that's okay. But if it stays like pinch, that means like, oh, this person doesn't have enough water. So you can like, one thing you can check for when you go out, during outreach, and someone's like, oh, I have a lot of diarrhea. Like, I don't know. One way to check is like, hey, can you, just pinch your skin real quick? And so we can assess that. And a lot of time when you don't have enough water in you, you can get headaches or confusion. And some other red flags that we should look for is very high grade fever. Then we need to be check in and be like, okay, this something's going on. This is not normal. Seizure or severe muscle cramp, and any prolonged diarrhea more than 7 days can indicate that this is not food poisoning or stomach flu. It might be that the client haven't ever got diagnosed for other stuff like Crohn's disease, irritable bowel syndrome, or other stuff that can cause diarrhea. So next we'll look at some prevention that we can, oh, I'm sorry, there you go. So what can you do? Like, what can we do when our client's having a lot of diarrhea? The first thing to tell them is drink a lot of fluid. Obviously, just tell them to start off with small sip so that the stomach can tolerate it. Don't tell them to pound water down because a lot of time they will throw it back up. And so hydration is an important aspect to treating diarrhea. And on top of hydration with water, another thing is electrolyte replacement. You can tell them to drink some Gatorade if they have, or Pedialyte, also some fruit juices if there's none of that. And another thing is to eat easy to digest food to give your gut a rest. One thing that I found is the BRAT diet. It stands for banana, rice, applesauce, and toast. So these are very bland food that's low fiber. It helps give your stomach a rest, and it's easier to digest. And with this low fiber food, it helps firm your poop or your stool, and it can calm your stomach and kind of prevent diarrhea. And also we can tell our client maybe to avoid caffeine, eating spicy food, greasy food, dairy, carbonated beverages. All of those can really increase stomach mobility, and it can increase diarrhea and worsen it. And a lot of time we want to promote rest. So when you have diarrhea episode, it can take a lot out of your body. So promoting rest for the body, telling the client like, just take it easy for the day, don't walk too much, just relax, that can help. And lastly, just seek care and for severe prolonged diarrhea. When if the client's like, hey, I've been having this for a while, just refer them to the primary physician to get checked up is the best thing that we can do. And lastly, we're going to talk about prevention for diarrhea. So obviously the most important thing is hand washing. We always want to wash our hands because the acute diarrhea is more likely to happen from a contaminated source or infection of some sort. So hand washing for 20 seconds with soap and water before and after going to the bathroom, or touching fecal matter or touching of any food can really help. So I split up the prevention between stomach flu and food poisoning. Stomach flu, since it is the virus, if you feel any type of symptom, like don't prepare food for others. So we can tell our clients like, hey, if you're feeling kind of sick, you've been throwing up, it's best if you don't share food, or if you don't like prepare food for other people. And use alcohol-based sanitizer and wipe all the surfaces of contaminated like touch area that they usually touch with disinfectant wipes or products like bleach. As for food poisoning, I know it's really hard for our clients to always, have the freshest food, but it is good to remind them like, oh, maybe try to get the freshest food possible. And a lot of time our client keep food, they don't really throw it out because they just find food, whatever is available to them. So we can tell client to look at the food and kind of smell it. Oh, does it smell kind of funky? If so, it's best to throw it away. Like, yeah, it might not look okay, but like if it smells kind of bad, don't eat it. And another thing that I think we should tell a client is maybe separate the food to avoid cross contamination. So if they find like an apple in the morning and they found a sandwich out of the dumpster like 2 hours later, maybe trying to keep it separate won't contaminate the food, and it can prevent them from having food poisoning. And if the client's unable to keep fresh produce, encourage like them to store canned food and seal food and eat the perishable first. Like if they have like anything that's perishable, like banana, apple, whatever that is, just tell them, promote that. Hey, maybe you should eat this first. And also lastly, kind of change their mentality a little bit and encourage them that there's a lot of resource out there for them, like food banks and a lot of places where they can get fresh prepared meal. Encouraging them that can really help prevent the current onset of diarrhea. And so lastly, I just want to say that diarrhea is a very common and it can happen to a lot of people. So a lot of time the symptom resolve by itself, but giving our client the knowledge that they can use to prevent the onset of one is very crucial. So if there's a takeaway from this presentation, just the key is hydration, hydration, hydration. So always tell a client to hydrate, and like that's the main goal that we want to have for our client. And that concludes the end of my presentation. If you guys have any questions. I know I didn't want to go over time, so I kind of zoomed past that.
Everyone's so quiet, but I'm never quiet. So thank you, Jenny, for your presentation. Also super informative. All of these have just been really informative. And I appreciate the key takeaway because, you know, and on outreach, oftentimes we'll have funders or people that can give small donations of like, what do you need? And often we're asking for water. Like we try to get reusable water containers for people that we run into often, or, you know, we get the just like plastic water bottles for folks on the street because, you know, they're sleeping outside and it's not only hot, so they're dehydrated, but I'll tell you, like, coming across folks that are sleeping outside that have diarrhea is actually quite heartbreaking because I can't even imagine being outside and having that happen to me. And so it was good to know too, to ask like how long have you had it, and you know, really encouraging them to get to the doctor if it's been more than a few days. So thank you for that.
Yes, thank you.
And I think if there are no questions, that wraps up our UCLA 3-part series. And I want to thank all of you for not only coming out and, you know, interning or volunteering with our outreach teams and me and Eileen, but putting together these presentations for us that, you know, we have recorded. And for new case managers, I'll let you all know because I had a program manager reach out to me to ask like how many more we're doing of these and how often we're doing them. And I had to let her know, you know, that it was only a 3-part series, but that they're recorded. And so she was really excited to know that she can send all of her new staff to the recordings to learn about all of these health conditions. So, you know, if it was one person or, you know, 800 of our employees, it was beneficial. So I really appreciate everything that you've done for us.